Very much for joining us. So I'll be sort of comparing the roundtable session today. So my name's Lauren Bevan, Head of Health and Social Care at BGSS. So I lead all of our industry propositions and run our sort of projects as far as health and social care organisations go. So that covers public, private and third sector. And I am gathered here today with our panel of experts. So just passing over to Lee Crosley to introduce himself, please.
Yeah, Lee Crossley, so Chief Engineer at BGSS. Effectively, my role is to make sure that we deliver the right solutions for our customers, and that is often within the healthcare setting.
Just hand over to Tim as well. You're on mute, Tim.
Unmute. Hi there, Tim Warpole, part of BGSS and also SPART, the strategic design part of BGSS. And I look at how to get value out of the organisation, particularly around user-centric delivery of services.
We appear to have lost Simon, so I'll give him his intro in absentia, assuming that he will be back with us in the not too distant. So Simon is our Head of Intelligent Automation at BGSS. So one of the things that we see as being critical to helping the NHS to be able to respond to the elective care backlog will be around robotic and intelligent process automation. So Simon is here in that guise, and hopefully we'll be back to talk to us soon. So one of the reasons that BGSS has been looking at this as an issue has been that through COVID, obviously there's been necessary cancellations of elective procedures and outpatients, and that's created a sizable backlog in terms of people awaiting elective care. So latest figures estimate that that's between 8 and 10 million people. There are estimates going all the way up to 15 million, but most people seem to coalesce around the 8 to 10 mark. One of the things that we've been looking at through our services around running the e-referral service for the NHS has been actually how are we able to help create a solution that helps the NHS to respond to these mass cancellations and rebookings for people, and how also are we able to give people peace of mind that their referral is being seen, and they will be seen by a doctor or a nurse at some point in the not foreseeable future. So on outpatients and elective care, so when the long-term plan came out in 2018, it was identified that outpatients needed some modernisation anyway. So I've worked in the NHS for over 15 years, and it's one of the things that's been identified as being exactly the same as when the NHS was created over 70 years ago. So there is already always a recognition going into COVID that it was a service model that was ripe for change. So one of the things that we've been looking at is around how citizens, healthcare professionals and organisations are able a little bit more effectively to be able to respond to the pressures that COVID has put on them, both in terms of the mass cancellations and rebookings and changing from appointments from face-to-face to non-face-to-face, which is a significant upheaval. Most appointments, I think it was 0.2% of appointments were non-face-to-face before COVID, so it's a significant sea change in the way that the operating model is delivered as well. So I've gathered intelligent experts, and I'll let Simon give his own introduction now that he's back. But what we wanted to do was just have a bit of discussion about how we think some of those solutions can be solved compassionately through technology. And we're really interested from thoughts from the floor about your questions and musings about what your thoughts are on the matter. So Simon, we introduced you in absentia, we probably did it wrong, so over to you to give your introduction.
Thanks, Lauren. Sorry about that. It always happens, doesn't it? The internet drops right at the most inconvenient time. But hopefully I'm back for good now. So hi everyone. Yeah, so I'm the Head of Intelligent Automation at BGSS, covering all good things in that space around robotic process automation and working with colleagues in AI and across data. So as we're having our meeting and conversation today, we'll draw out those elements together and talk about how they're relevant to elective healthcare. Thanks, Lauren.
So I guess the first question is, I've already alluded to the fact that there are ranges between 8 and 10 to 15 million of people waiting. In terms of using data and forecasting techniques to really understand where we think that where the queue is, how long is the queue and how poorly people are, I guess interested in thoughts from the panel around how you might be able to use data ethically to make sure that we're making the right predictions.
I didn't realise that my first sort of answer was going to include the word algorithm, because there's been quite a lot of bad stigma attached to that recently, and making ethical and fairness is another kind of difficult question. So I guess that estimate, I mean, why is that an estimate between 8 and 10? Is that because people potentially aren't going to their GPs for the risk of catching COVID, or is it because, you know, we don't have the data in the right systems, or they're disparaged over multiple? Do you know what I mean by that kind of question?
Yeah, so I think having done quite a lot of capacity and demand work in the NHS is always an element of art to the science. But I think that there are a couple of points that I would bring out. One is that normally you'd use a 3-year rolling average, whereas at the moment that's really difficult to do because we're not in normal times. So that historic data becomes less and less useful to dealing with what our understanding is of the present day. And there is an element where GPs have been super busy. I know there's been quite a lot of controversy around people indicating that maybe they haven't been open for business when they have been, and they've been working incredibly hard. But there is a different mix of people going to them for different things. So obviously the service model has moved to a remote consultation model, and that necessitates people feeling able to see and discuss certain things. So if you've got a lump or a bump, it's actually harder to do that over the phone or over video. You would probably prefer to go and see somebody. So I suspect there are some of those people who are holding back on those sorts of concerns.
Yeah.
And the other thing is around the acuity of things. So we're more likely to see people presenting to A&E with certain issues because of that factor that they've not sought help early or haven't wanted to inconvenience people as well, because I think there's a certain generation who don't want to bother people, and they're likely to have unfortunately worse outcomes if they don't seek care and attention sooner.
Yeah, it's that British stiff upper lip mentality, isn't it? And then it gets too bad and it becomes more of an issue. So there was a few things there that I kind of want to talk about, which is the data that we're getting, and you said about fairness. If we're doing more remote consultations, and I agree we probably can't do remote ops yet, you know, people holding iPads in their mouth and things, but you can do sort of pre-ops and questionnaires and check that way. But are there people that you know, might not have these iPads or devices that are potentially excluded from that as well if they can't do that? So are we already making the system slightly unfair by trying to kind of help the system move along a bit faster? The next bit was around about the sort of the data itself. So obviously data quality is paramount in something like this. You could have the best algorithm in the world, but if your data is wrong, it's very difficult to kind of get any useful insights from it. And we don't seem to have that much data, like you say. It's sort of 3 months, not 3 years or 6 months, depending on how you're kind of cutting it. So yeah, I mean, one thing that we sort of pride ourselves in is doing things like data ops, which is a sort of methodology to create fast cycle times around getting your data and assuring that quality and getting fast feedback as well. So you probably want to look at setting that up in the right secure way first before you start bringing data to your data scientist or whoever it might be, so that you've got that sort of foundation built in from day one. In the interest of fairness, I mean, I'll let someone else pick up the sort of what they think about how we can make algorithms more ethically fair.
I feel like this is something that Tim will have a view on. Tim, interested to hear your thoughts. You're on mute again. Second time, second strike.
Am I out if it's third strike? We've all heard the stories, I think, of unethical data or data which has gone wrong with a conversational AI and things that gets trained to be unfair based on human nature. And I think whenever you come to this problem of looking at the data, you need to think about how potentially could it go wrong? How can we mitigate that to make sure that the data is correct? And we need to look at the edge cases always, rather than this is the normal stuff and we're happy with that. It's those edge cases that need to be really thought about so that we can make sure that the data is right and it's right for everyone. And it's about that continuously monitoring as well. The fact that you've done something right on day one doesn't actually mean that in 3 months' time it's going to be right, because something might be going wrong with the model, and you need to be constantly reviewing and testing that model as we go forward to make sure that it's continuous and right.
And I think given that we're in a situation where we've got local lockdowns and other things, there's going to be a regional element to how this gets done as well. So making sure that we're able to look and see how things are trending, and again, from that exclusion perspective, to make sure that we're cognizant of that. Because I agree, Lee, that there'll be some people who are not comfortable, or don't have the technology, or aren't comfortable, or have a certain disability, which means that they can't interact with healthcare services in the way that other people are at the moment. So definitely need to be very cognizant of that. So one of the things that BGSS runs on behalf of the NHS is the e-referral service. So we have good line of sight around actually understanding how that system gets worked, and are able to see, and it's publicly available data around how many referrals are going through the system. And we know that has dropped significantly, particularly for cancer referrals, which are under a 2-week window. So from our perspective, we remain, I guess, concerned that some of those people are going to present later on. And we know from historic data about 30% are referred with query malignancies. 30% of people get found through normal routine outpatient settings, and about 30% present in A&E with severe symptoms. So at the moment, by keeping that queue and that backlog is significant, is probably going to skew those percentages significantly to that present in a routine outpatient clinic, or present in an emergency care setting, which is obviously something we'd like to help avoid, and like to sort of think about how we can use intelligent data predictions to be able to look and see how we're able to identify those people who are in that second cohort of have already been referred, but those symptoms and those signs haven't yet been picked up, and they haven't been fast tracked through to the front of the queue for some more urgent attention.
Just thinking a little bit more about the sort of identity as well. If people are in lockdown in a place where they don't necessarily live, and it's a sort of different GP that they go into as well, you potentially spinning up lots of different temporary addresses for individuals, making sure that you're getting, letters, notifications, things out to the right people, and associating identities, techniques like association mining or fuzzy matching, making sure that you're not accidentally sending somebody the wrong thing, or even worse, somebody not getting a notification that that they actually have an appointment and they don't turn up to it, and then you've completely wasted that slot.
Yeah, absolutely. And I think it's something where normal outpatient services, there's all sorts of reasons why it is not particularly effective, and the reason why it was brought through in the long-term plan as an area for right for change. But I was at a conference, obviously pre-COVID, where it mentioned the NHS is the largest purchaser of second-class stamps. And I think it's something like £2 billion or something that it spends on those stamps, which is predominantly for outpatient letters. So there is a huge efficiency and efficacy thing, because you're then reliant on a postal service for something which most people for other areas in their lives would expect to receive email notifications or SMS notifications. So again, there's a modernisation piece which underpins all of this.
There's a delay there as well when you're sending something via snail mail. We call it snail mail for a reason. You can't quickly chop and change appointments quickly, can you, if you're sending out letters?
And given the rapidity to which the shifting sands around the policy landscape around COVID and local lockdowns are changing, if you're relying on a postal service to tell someone that their appointment has changed, the location has changed, the time has changed, that delay becomes problematic. And there's a likelihood there that people will be turning up to hospital where they're not necessarily safe, eligible to be there, and are likely to be turned away after the inevitable battle for a hospital car parking space. And that isn't great patient experience for anybody. So I think there is and obviously there's an underlying patient experience part to all of this, but I think that most people want to receive things in a different way. And I agree from an equality and diversity perspective, we should be making sure that we have omni-channel communications. It's not all about internet facing stuff, but at the moment there isn't an option to do it other than postal for most places, and that feels like it doesn't belong in 2020.
I think that omni-channel, that multi-channel is really important. You still need to probably cater for those that wish to be able to have via snail mail. There are people that I mean, my father is probably the case. He would want a letter because he'd turn up with his nice letter. But looking at the millennials and things, and even me, I really do not want those pieces of paper. It's slow, it's inefficient, it costs large amounts of money. It's not sustainable. And for those that want that, it should be able to look, I can have it digitally, I have it via email. I go onto the portal. So why cannot I log on and say, look, please tell me where my appointment is today? And actually, if it changes, then I'll send you a notification. And it may be that as we go into a new phase of lockdown, your appointment that was going to be 3 weeks ago is now pushed by X number of weeks. And you need to be able to have that repetitive update to say, look, I can be proactive about understanding where it is. Or actually, I need to be able to reverse, actually tell the GP or the hospital that I'm no longer able to come in. Yeah. So I want to be able to say, actually, I'm no longer able to come in because someone in my bubble or my household has symptoms. But if they get tested and they're clear, then I can actually say, oh, I can come in now. And you need to be able to do that rapidly. I'm not going to send that post back to the NHS. It will never get through, I'm sure.
No, and I think on that basis, at the moment, the service model, and this is why we think there's an RPA solution as well as a data and AI solution underneath it, is done by hospital administrators in an outpatient's booking office. So at the moment, their office hours are 9 to 5, Monday to Friday for the most part. And they obviously do great things. They'll call up people, they'll check things. And for certain sections of society, that's really important for them to understand where they need to go to be able to ask questions and all those things. But the volume of transactions that need to be taken through a reasonably small part of the workforce, and one, again, who are potentially self-isolating, not necessarily able to work unless they've got remote desktops and other things, that they need a tech-enabled solution for them to do their job elsewhere. Again, I think I'm interested in Simon's view from an intelligent automation perspective around, is that the sort of thing that we should be looking at, or the NHS should be looking at to automate?
Yeah, thanks, Lauren. I mean, it certainly is something where robotic process automation and that the wider sphere of intelligent automation can help. I mean, the key thing to first of all think about is those robots are there 24/7, and actually we have to think of them as part of our workforce. So the key is to let's get them working for that amount of time. So it straight away gives us that uplift in capacity. Clearly, what we're looking for is to help people with those high volume processes they've got that are slightly mundane, that are dragging them away from that real value added judgment, thinking, decision activity they've got. So anything that's basically high volume, structured data, rules-based is ideal for us to put RPA against. So in this area we're talking about here, the patient booking process, scheduling process, it jumps from different systems, requires different inputs. That's a classic great use case for improvements to RPA to effectively free up people's time as they get this bottleneck. And we're seeing that benefit elsewhere already in this current environment, particularly with contact centres or rebooking, be that whatever kind of nature that rebooking is. We've got use cases where we've condensed 3 months worth of work into 10 days using robots and delivered a great outcome for the end customers and the clients. And that's something we should be thinking about here. There's definitely a benefit. But also let's come back to the piece we just talked about around data. So we do only have that 3 months of current data, but we can see there's a significant problem building up. But the beauty is we've got years worth of real historical data. So what we can do now with robotics, but we're taking that into that intelligent automation space, so which we're thinking in judgment, is we can mash up the current data and start predicting using scenario-based against the historical data where proactively we think the problems are. Now, once we've got ideas of what the problems are, we can now verify and dive into those. So if we think we're building up potential poor outcomes for people who haven't gone through elective care for, say, potential issues such as cancer, we can start identifying those groups of people and proactively, either by public generic messaging or potentially targeted messaging, those groups, try and pull that forwards. So not wait for it to hit us in the future, but get on the front foot, use the historical data with the current data and the computing power we have from AI and RPA to start alleviating the problem and smoothing it out. So if you want to add to that in terms of that artificial intelligence judgment on trying to break down the queue.
So I think that there's quite a few things in that I think are important to pull out. I do think that there are certain signs and symptoms which are clinically known as kind of red flags, that are things that when I used to be clinical and you used to see people in clinic, that they would sort of mention a sign or a symptom and you would go, "Ooh, I think we need to address that, and we need to talk about that in a slightly different way, and we need to accelerate that." I think there is also something about how there's likely to be a bottleneck around things like diagnostics. So CT, MRI, there's likely to be a different dependence on the private sector than there typically has been for the NHS, just to push through those diagnostics. And I think being able to work with the places where we think that the sort of downstream dependencies are for the patient pathway, and being able to work with those people to allow them to capacity plan properly will also help as well, because it's not just about the sort of single patient journey, which is often a unique kind of view through NHS services. It's also about capacity and resilience planning from staffing, equipment, all of those other things that are required to take a cohort of people through a patient journey. And I think using that AI to be able to give other providers a view around planning and their planning capacity will probably help them to be able to better serve the needs of the NHS and to get people a diagnosis quicker, which is really what people want. And people, I can understand if you're kept waiting and not knowing what the next step in your pathway is or how long you're going to have to wait. That's a significant sort of mental stress in the time that lots of people are finding it quite difficult. So I think anything that we can do to help people on an individual and on a regional and national level to be able to respond to that and make sure that patients are informed, have got a view about how long it's going to be until they get their next step, and is this as bad as I think it is, I think is super important.
That not knowing, how when your appointment's going to be, and not feeling like you're even in the queue sometimes is frustrating for some individuals. I was just thinking a little bit more about what Simon was saying, and there's so many different data sources that we're probably not even considering at the moment, like weather data. If it's, got a schedule to be snowy for the next week, and you're up in the Scottish Highlands somewhere, or anywhere where, you might be a significant distance from where you're going for surgery, and you're elderly, or something like that, you could probably say that you're not going to turn up to this, proactively say, do you think you're going to be able to make it, and do those double checks, and also remove that reliance on the staff which are having to do this using those RPA tools, which, if the systems themselves are not fragile and it's very easy to automate, then that's a great sort of tactical use, isn't it? The sort of other data sources is the media as well. Something goes on Twitter, and suddenly, if a celebrity has cancer, or there's something which is really mainstream, it can impact and throw out your predicted demand and things as well. So I feel like there's lots of different data sources that we're not utilizing at the moment that we could very easily kind of tap into and feed into this.
And the interesting thing is that this is relatively quick technology to implement and set up, so we can deliver value in days and weeks rather than multiple months. So in this current situation where we've got these problems building up very rapidly, the fact that we can quite quickly start adding value and turning around and trying to work out answers to these really important questions is incredibly valuable. And that's something that's not really been in place before, and that's something that is quite unique now in the last 12 to 18 months that we can start actually doing and facilitating. So I think that's pretty interesting as well.
And there's some questions from the audience. So there's one around whether or not bidirectional integration with EPR where applicable is preferable to using RPA. So I'll give my thoughts on it and I'll hand over to Simon for his. But in terms of that bidirectional integration, so again, I think if we were dealing with normal circumstances, and by that I mean that the patient pathway would be delivered through with one trust, then I would say, yeah, probably. To their own appointments and reminders and all those things, I think that would definitely be a good way to go. However, I think what we're starting to see at the moment is again what I was referencing around people needing to go to independent sector for diagnostics or other things, that actually the care or the elective care pathway is likely to be provided across multiple providers, I think, for at least the next couple of years whilst this backlog is alleviated. So I think that patients should have access to their own records, and they should be able to see all of those things. But I don't think that it will necessarily help at the moment, where I think it's going to be a real team effort for lots of different care providers to come together to be able to provide both the diagnostic and the treatment pathway for patients. Simon, I don't know if you have any thoughts on that.
Yeah, no, it's a good question, because one of the things also we're talking here, specific problem we're thinking as a group, what our potential solutions will be. But when I and us as a team, we as a group go and talk about RPA, intelligent automation, it's certainly not a one size fits all. And quite often we can appreciate that we might have thought something was right for RPA, but actually when we understand the problem specifically, there's a better or different solution to be suggested, and vice versa. And that's one of the great things about us as an organisation, is that we have that engineering heritage and we have those other skills, and we're constantly looking for what is the best outcome for our clients. So it might not be RPA, it could be some pure engineering, it could be a workflow solution, it might be a more specific and say business process solution here. But ultimately, it just depends on what we consider the problem is and what we're trying to do for the client. But the key here is about speed, and because the RPA tooling is a low code tooling set, it gives that opportunity to quite rapidly set something up, be that a tactical interim step or something more strategic. And that's kind of the key benefit here, is that speed, which perhaps we don't get with some of the other solution sets, which ultimately might be a better long-term solution. Did you, Lee, want to add to that at all, or Tim?
I think you covered that pretty well, to be honest. But yeah, engineers actually like to deliver value, especially the ones I know and work with anyway. So when we did the sort of tactical RPA solution for another government sector organisation, turning something around and seeing those results and seeing those users suddenly not frustrated anymore, engineers like that, even though it was, this sort of low code platform that we're talking about there. But yeah, you hit the nail on the head when you said it's about looking at what the problem is, not throwing a solution at something. So you want to always look at what your problem statement is, not a solution statement, and make sure that you're doing the right thing that delivers the right value that addresses that problem. So yeah, I'm 100% behind that.
I'd agree with everything there as well. As Lee said, it's about releasing that value, but I think it's about particularly around, we're talking about users here, it's about that user-centric discovery to understand what is right, but also being able to do that with some tooling to be able to rapidly come up with a solution and then actually see if that solution works. So maybe to do a little bit of experimentation to understand what is right before delivering that final solution. And if it's wrong, actually to be able to say, look, it is wrong, but very early say it's wrong, reiterate around it until we get the right solution, and then actually go forward with something that is going to deliver that value to the organisation.
And I think we've got another couple of questions from the floor. So one is around product. So there's a few products out there who are obviously looking around digital letters and appointment management. So people like Doctor, for example, and Zesty, who have obviously seen this as a problem statement as well, and have specific products that are designed to tackle outpatients and outpatient communication. So the question is where we see the future of these services going. So again, to sort of reiterate, I think there is something about what is needed for COVID versus what's needed, I guess, for peacetime in the NHS, which I think are different problem statements. I think the issues that the sector's dealing with at the moment, hopefully, are not going to be persistent issues. So I think there are some specifics with respect to local lockdowns and, isolations and even isolation duration, which obviously is rapidly changeable, that I think require something that is a more iterative solution, as Simon's referenced, rather than I think these products which have obviously been designed and refined over a period of time, which I think are more suitable to kind of peacetime outpatient management services. So I think my view is that there's still definitely a place in the market for them. They do a great job. Lots of people use them a lot, and they seem to really work for patients and the organisations that they work with. However, I think that the problems that we're dealing with at the moment present themselves with a different set of problem statements that require a different, more tactical set of solutions. But again, I would welcome comments from the floor.
Yeah, I mean, reiterate your comments there. There's definitely a place for these solutions. So let's think about this as you know, wartime or peacetime or whatever we are in at the moment. It's about the digital transformation journey. Actually, what we're talking about here is a subset of that digital transformation journey. And that question there is that other elements of that journey. And it's great to see, you know, innovative people bringing new solutions to the market and start to then drive those and iterate them. And we can see pieces merge and morph over time as we try and go through that journey to transform, which we kind of start thinking about in our space as a hyper automation journey. So what does the end goal, what is the blue sky thinking in the future? And those sort of elements there, they certainly play a part in that. But as you say, at the moment, we need something that's proven and it's quite rapid to solve the current problems. And that's why we're talking about something like around intelligent automation, around AI chatbot tooling that we've already got up and running, around RPA tooling that's enterprise-led, got multiple clients that can prove it can work. So definitely a place for it. At the moment, I think there's a bit of focus more on what's doable and what's achievable quickly to solve these real problems we've got now. Over to you guys for your thoughts.
Yeah, I think I don't know all of those products, by the way. I know a couple of them, but there's obviously challenges with taking an off-the-shelf product anyway, because how do you do due diligence? You know, where's the data stored? Would I be happy as a citizen having something stored by, you know, a company that's potentially American or stored in another country? And what are the security and privacy implications around that? What's my data potentially being used for? But aside from those kind of challenges, you've got the actual integration challenges. So what we're talking about here is quick tactical solutions to get things out quickly. If you're looking at a product and doing the due diligence on it and then looking at their APIs and integrating it into some potentially old system that you can put RPA over the top of, you're potentially slowing that solution down as well. So I think that, well, if there is a product that was fit for purpose and you did that piece of you know, discovery work and figured out that it was solving the problem, absolutely use it. And you know, maybe it is a combination of all of these tools together. It could be that RPA is feeding the data into it, and you know, you've done your due diligence and the data stored in a hardened NHS environment. So I guess it depends on what the thing is that you're solving and picking the right product and never going product first.
I'm going to add to something you said there, Lee. I think you brought in due diligence on other products and where the data is stored. And that brings, particularly in this agile world where we need to get something out that's tactical, those challenges around that security and that governance about where the data is. So not only do we need to be able to do something rapidly, agile, we need to experiment and do the right thing, but we need to do it in the mindset of secure and data centric. The data is in the right place, so we have to come at it with the right approach to that data security as well. It's not just about throwing up a system that answers today's problem. It's about doing it in a way that is secure, and the data that we are passing through those systems is secure and not stored in China or America or somewhere where we don't want it to be.
Yeah, I guess bringing test data to the systems as well for or the right kind of access, and decoupling that data model from your actual data and things like that. You need to kind of then map those to these products and have a look at exactly how that works. The beauty of RPA and why it's sometimes a good solution is if your underlying system, you know, has a web UI and you're running it as a sort of attended robot on somebody's machine, actually, you're not really moving that data around anywhere else. All you're doing is helping that member of staff do their job more efficiently. It's not that, you know, you're replacing them or you're storing data somewhere else in the cloud, as long as you're careful about logging and things like that and persistence. But yeah, it does actually cut through some of those challenges that you have around governance, which I'm surprised we've not said that word yet, but yeah, governance.
Yeah, as an ex-Caldecott guardian, then I'm very glad that we've all talked about that. So there's a couple more questions, one of which I know Lee is going to love, so I'm going to leave that one till the end because I suspect we might not. You might go off on one on this one, Lee. It's a good one. There is a really good question here around imaging data. So investigations between providers in terms of transferring image data from independent sector. And I know I had a hip CT scan about 18 months ago and was given a nice CD-ROM of my hip CT to go and look at and peruse in my own time. And I think it's the only place where sort of that sort of storage device is given to people to transfer between providers. So the question is around how machines can take this on, around whether or not the rules around PACS should be reviewed to say fit for purpose. Yes, I believe they should be. And around the view around how we're going to integrate and automate providers' data exchange. So if people are going for different parts of their pathway and different things, and the tests are being done by different providers, how is that going to be unified, and how is the person asked to make that clinical assessment across all of the tests that have been diagnosis have been done? How are they able to sit with all of that at their fingertips in the way that they need to be? So, and then my personal view on I guess RIS PACS in general is that it was designed for proprietary systems and it was designed with privacy in mind, but because before all those guardrails were put in place to allow people to safely and securely transfer data, I think the guidelines kind of were based on pipes rather than cloud, and I think there is a definitely need for a rethink, especially in light around the cloud hosting principles that NHS Digital came out with a couple of years ago. I think that needs to be used on a wider pool of data. So my sincere hope is that will happen, especially with the chest X-ray imaging set that NHSX have been working on as part of the COVID response. My hope is that will change the view about how diagnostic imaging and the metadata that sits underneath it will be shared and used for clinical utility a lot more. And I think that there is a view that we need to think about system interoperability in the way we think of it around EPR providers from a imaging providers perspective, so that actually you're not kind of locked in around proprietary image sets in the way that you are at the moment. And I do think there is an RPA process which can help to lift that data and do that data transfer processing and checking, which I think is super important, because there's a huge amount of cost which gets put into the NHS around retesting, because if it's been done and ordered by somebody else and it's not somebody you know, it's really hard to have faith that they've done it to a high enough quality for you to base your clinical decision making on it. So I will stop there and seek counsel from the rest of the panel on their thoughts on it.
No, I mean, I think touching on an area we've not talked about here at the moment, but around data security and encryption. I don't really understand the particular process there, but if there is a process in place, be it manual, how it's done, you transferring data between different systems, that's obviously something that would be we could look at from a bot perspective. Inbuilt into those type of solutions are encryption and data security. I did understand the process here a bit more fully, see whether that was appropriate or whether it's actually taking upper levels you're talking about there as well, the cloud security strategy rather than the traditional network environments that we've worked with more historically. So yeah, in theory, yeah, an RPA process, but longer term, I just need to understand what the security constraints and rules are. I'm sure there's a lot of regulation around that type of data being transferred. So we need to consider that fully. Tim, did you have some thoughts?
I was slightly going to go off topic on the vision. I think there is a lot that can be fixed here. There's a lot of problems, and I think we kind of touched on it at the beginning. It's understanding where we can easily release value into the organization. So there may be parts of this journey that are just not fixable at the moment in the timescales using the services that we have. And it's being able to identify quickly, this is something that we can look at, we can release value, we can do it in a rapid way, and we can actually get something sorted, and then we can look at some of those other problems. So transferring data between systems is probably, particularly some of those large scans and things, is probably not something we're going to be able to do overnight. And there are some other bigger problems that we may be able to tackle. And that's the first thing we need to be able to do. Look at the problem statements, look at where we can release value quickly and go down those routes. It's what we call potentially a lighthouse project. So you might have heard of lighthouse projects, being able to look at that and release value quickly into the organization. And that's where we should start.
And one of those factors that you can look at is those different kinds of security requirements and levels. So, you know, for some operations or for doing some things with data, you might not need quite the same strict governance around it. Think about, you know, open banking and secure banking. You know, you have to step up an extra level to perform, you know, a transaction as opposed to just looking at your balance and things like that. So, I mean, if you can unlock value here and it's a little bit too difficult to do the next step, then maybe you don't need to do it immediately.
And the final question, which I'm going to put to Lee, because this is his sweet spot, is whether or not there's an IoT product which could be deployed by some NHS providers to help with prioritising backlogs.
Lots. There are lots of IoT products. In fact, I'm happy to do technical specs of all of them. To help with backlogs. Okay, so there's the obvious one that jumps out to me is if you did sort of Bluetooth tracking within the clinical settings themselves. So if you were, you know, in your wristband, you had a Bluetooth transmitter and you had a number of Bluetooth gateways or beacons dotted around, you could actually track what the patient flow looked like. You'd be able to see if there are efficiencies there. Can you let more patients in? Are actually patients not adhering to social distancing in certain rooms, and look at the quality of care there? And that actually could, you know, increase the flow. And they're super low cost items as well. And well, actually more importantly than that, even though that's Internet of Things, they don't need to be on the internet, right? They can stay local in the trust. You can keep that privacy. You don't even need to have it associated with the user necessarily. It could just be an ID of the thing on the wristband. So I'm not advocating that we just send patient data everywhere and their locations, like potentially we might be doing with mobile phones. So yeah, I think other IoT devices, unfortunately, there's a barrier to entry when it comes to cost for a lot of things. If you want to do diagnosis in homes and things like that, the costs are coming down, and there are a few sort of experiments going on at the moment. But the more bigger machines, you know, that actually doing the temperature checks and the image scans, chest X-rays and things like that, and the sort of things that you see in airports when you may be coming back from China to see whether you might be you might have a temperature and that kind of stuff. So I guess those are already in existence, but yeah, there's a huge cost to entry, and you can't put things in people's homes to help diagnose stuff quite so easily.
And again, with my MedReg head on, then they're changing the boundaries around what's classed as a medical device as well. So that's something obviously to be cognizant on around. They're sort of lowering that bar in terms of what is classed as providing guidance or diagnostics, and there's fewer people to, you know, the barrier to self-certification has dropped quite significantly. And there's just one final question before we close up. We've got 2 minutes left. So there was the news a couple of days ago around the large AI award around DHC, around there were any projects to tackle these issues. So I think there were some products or some projects which were looking to think about queue prioritization. A lot of them were more diagnostic projects, I believe, certainly in terms of the phases 2 and 3. I'm not sure on phase 4. I didn't get that detailed into the press release, but I think there are a few people that were looking at queue prioritization as part of that from an AI perspective. So I do think that is something that others, you know, people are thinking of in terms of it being a useful tool to be able to solve the problem. So I think there are a couple of people also thinking along the same lines as us, which is comforting, I think. So I'm conscious that it's coming up to 3 p.m. and I'm just going to draw the session to a close. So I'd just like to say thank you to everybody for your participation. Lots of great Q&As there, and thanks ever so much for your time.
Well, thank you so much, guys. It was really interesting. For anyone that joined, we will be sharing the recording after the session, and there'll be a curation of any of the questions that you've asked. So if there's anything that we've missed off and you want to continue the conversation, please do just drop me an email, and we look forward to seeing you all soon. Thanks very much for joining today. Take care. Bye.
Thank you.